Migraine affects approximately 14% of the worldwide population and is the second leading cause of disability. For the acute treatment of migraine attacks, multiple treatment options exist. In a systematic review funded by the Agency for Healthcare Quality and Research, our group found a high strength of evidence to support the use of triptans. However, the systematic review also found that patients with established cardiovascular disease or at a high risk of cardiovascular events were often excluded from clinical trials. My name is Zhen Wang. I am a professor of health services research at Mayo Clinic in Rochester, Minnesota. I am pleased to share with you our article entitled Safety of Triptans in Patients Who Have or are at a high risk of cardiovascular disease, a targeted trial emulation, which will be appearing in the November 2024 issue of Mayo Clinic Proceedings. The reason behind this is because triptans are considered vasoactive and are contraindicated in patients with cardiovascular disease or who are at a high risk of cardiovascular events. Yet triptans are highly effective for migraine and remain frequently prescribed for migraine patients in various clinical settings. Therefore, we conduct a targeted trial emulation to evaluate the safety of triptans in migraine patients with cardiovascular disease or multiple cardiovascular risk factors. Targeted trial emulation is a type of research methods based on observational data to emulate a pragmatic randomized clinical trial. If done correctly, the targeted trial emulation can yield the same effect estimate as that of a real clinical trial. In this study, we hypothetically assigned patients to triptans or non-triptan treatments. Data were retrieved from Mayo Clinic electronic health records. We include all adult patients with at least one visit at any Mayo Clinic sites between January 2000 and August 2022. The primary outcome was a composite of major adverse cardiovascular events, MACE, at 60 days of starting treatments. MACE was defined as all-cause death, non-fatal myocardial infarction, non-fatal stroke, heart failure, transient cerebral ischemia, or revascularization. Secondary outcomes included the individual components of the composite MACE outcomes. Propensity score matching was used to balance the difference between patients who received triptans and those without triptans. 3,518 patients who received triptans were matched to the same number of patients who received the non-triptan treatments. The median age of the study population was 55 years. 81% were female, 90% were white. 33% of the patients had a chronic migraine, while 27% reported aura. The study groups were well balanced in terms of demographic and clinical characteristics. The median time to MACE was 5.5 days with triptans compared to 15 days with non-triptan treatments. The absolute risk of MACE and the individual components of MACE was overall low for both groups. At 60 days, 1.48% in the triptan group had MACE compared to 0.37% in the non-triptan group. The difference was statistically significant with a relative risk of 4.0. Patients treated with triptans also had a significantly higher risk of non-fatal myocardial infarction, heart failure, and non-fatal stroke. 5 patients in each group died. The findings were consistent with various subgroup analysis and sensitivity analysis. In the United States, there are over 3 million adults with migraine who have contraindications or relative contraindications to triptans. Identifying a proper treatment in these individuals is challenging. The current study showed increased risk of vascular events with triptans in patients with migraine and cardiovascular disease or risk factors. It is notable that the overall incidence of these events remained low. Hence, shared decision-making remains important to trade off benefits and harms. The current findings support the continued avoidance of use of triptans in patients with cardiovascular disease or risk factors. It is important to note that in recent years, a number of new migraine-specific treatments have been developed, such as lasmiditan, rimegepant, ubrogepant, and zivegepant, and that may be good options for patients with contraindications to triptans. I thank you for your attention and invite you to read the full article appearing in the November issue of Mayo Clinic Proceedings for further details. Thanks again.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com/Mayo Proceedings. Our journal updates on Facebook, www.facebook.com/Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.